Thank you, sir, for having me on your course, and good afternoon, and thank you for being here on the last session. So as Dr. Pandav said, is your job done once you complete surgery? Well, hardly, because surgery is beginning of a process that takes several months to complete, and alterations in the bleb morphology and aqueous outflow due to the scarring response always influences long-term success. So therefore, appropriate management at the appropriate time is essential to ensure a good functioning bleb. So maintaining your bleb after surgery is more difficult than doing the surgery itself, which is one of the problems with the trabeculectomy. So what is the ideal trabeculectomy bleb like? We'd all like to see a diffuse, mildly elevated bleb with normal conjunctival vasculature, visible fluid, yet the scleral flap visible, a well-formed anterior chamber, a tightly closed conjunctival wound, and a patent sclerostomy. So that's the end point which all of us wish happens and remains for the rest of their lives. And what we definitely do not want are scarred blebs like this, a tenon cyst, or maybe even thin cystic mitomycin blebs, or scarring, a retraction here, and maybe a Seidl's positive leak. So we don't want these things. So basically the bleb management is to prevent blebs like this and get the ones we want. Now, like we've said throughout this course, the problem with the trab is that we expect miracles. The idea is to create a fistula from the AC to the subconjunctival space, but then if it's a wound, it's going to heal. But what do we expect? We want the subconjunctival and subtenon space should not heal. They should continue to filter. We want the conjunctiva should heal perfectly with no wound leaks. And we want the scleral flap should heal partially, just enough for aqueous outflow, but not so much that the IOP rises. So it's quite a miracle out of the surgery that you want, and it's up to you to make that miracle happen. So if you successfully manage a glaucoma filter after successful surgery, the miracle that you see down here usually happens in the long term. So I'm just going to go through a usual postoperative course of trabeculectomy, which should make most of the miracles happen in most cases. Frequent monitoring is of optimum use. Now, allowing changing in bleb characteristics to be identified. That's the main thing. If you monitor them frequently enough, it's only then that you will be able to know what is going on in your bleb and what is to be done. And there is an early window of opportunity to modulate these changes. So the first 6 to 8 weeks are crucial, really. So the monitoring that we usually do is about weekly for the first month, 2 weekly for another month, and then depending upon the bleb and the intraocular pressure, you need to call your patients back. So this is what it usually looks like in the first 4 to 6 weeks, and we'll go through what all is done. Now, on the first postoperative day, expect a moderate amount of inflammation. So what they require is topical steroids and cycloplegics. If the IOP is high, it's a good idea to massage the bleb and do just that. Now the bleb massage, what we do is a digital pressure to the globe through the upper eyelid, just posterior to the lip of the scleral flap. So rather than go inferiorly, that has a danger of the iris plugging the sclerostomy, it's a good idea to go through the upper lid and just press on the scleral flap adjacent to where you've made it. You'll have a little bit of fish mouthing. The aqueous just comes out for a second and your intraocular pressure comes down. So it's better always to have the intraocular pressure in the mid-teens postoperatively. Do not have your blebs or your pressure, down to the lower 5s or 6s, because those are the blebs that are likely to fail. So mid-teens, high teens is a good IOP to have at the end of surgery, but be very careful not to shallow the AC, so be very careful with your massage. Now, in the first postoperative week, the bleb is usually quite vascular, and if you have excessively corkscrewed or inflamed vessels, subconjunctival 5FU is a good option. So this is always given under aseptic techniques, but we give it under the upper eyelid, on the slit lamp, but away from the bleb. It's always directed away, so it's about in the 90 degrees. But I've put this in as to just caution, if at all you want to massage it and you want to give 5FU, please massage before 5FU. And this I learned the hard way We gave the 5-FU and then thought the IOP should be a little less, and we gave a gentle massage then. What happened with that is the 5-FU went straight into the anterior chamber, and in front of our eyes, the cornea turned white. So you're almost thinking that now you've done it and the patient is going to need a keratoplasty. But usually if this happens, the heartening thing is over the next 4 to 6 weeks, the cornea does clear. But that's not reason enough for us to be careless and give a 5-FU and then massage it. So be very, very careful. The 5-fluorouracil is toxic to the endothelium and it should not be entering the eye. The next question is when to manipulate the sutures. We've all seen the various types of releasable sutures that are used in the previous presentation, but the IOP is still high or excessive pressure required for massage, then it's a good idea to release that suture, or you can do laser suturolysis if you haven't used a releasable suture. But usually it's done within the first week, at the most within the next week, but doing a suturolysis after 2 weeks is usually of not much benefit because the sclera has already started sticking down. So you need to have a loose scleral bed for a suturolysis to open it up and the IOP to come down. So just within the first 2 weeks would be a good time to plan your suture removals. Usually we do it within the first week. So typical course in a young patient, a juvenile open angle glaucoma, would be day 1 receiving frequent steroids, day 7 a suture removal and a 5-FU, and by day 21 you're on your course to having a reasonably good bleb. Now I'll also touch upon what if the IOP is low. Look at the bleb. You could have a high bleb with a shallow AC, well that means there's overfiltration. Then you could just get away with a pressure patch, some atropine drops, but if there is lenticular corneal touch, then you would require to reform the AC. If there's just peripheral iris corneal touch, don't panic. Mostly, just with cycloplegic and frequent steroids, these ACs get back and the blebs can be managed. But if it's low with or without a shallow AC, look carefully for a leak. And if there is a leak, don't sit upon it and hope that it'll get all right by itself. It usually doesn't. Take the patient back to the OR and resuture the conjunctiva. There's no problem with doing that. And while all this is, don't forget that you could have postoperative choroidal detachments or retinal detachments which could be the reason for the low IOP. So don't just think it's a trabeculectomy. Look at the eye. Do look at your posterior segment and be sure that there's no problems going on behind the eye. It's important to recognize a failed filter and look at the reason for the failure. If the IOP is not reaching a desired target and there's a morphological feature of scarring or encapsulation, usually the IOP is more than 21 millimeters of mercury or a reduction of less than 30% of initial IOP. That's what is called a failed filter. So depending on what the cause is. So if you have a scarred bleb like that, maybe a needling and a 5-FU could work. If you have a tenon cyst like that or a bleb like this, most likely they'll have to be revised. So there are lots and lots of bleb classifications but the one that we read while we were in PG, the Cronsfield's clinical classification I found is the easiest to remember. A type 1 is a thin polycystic bleb. A type 2 is a flat, thin, diffuse occurring bleb. These are the two blebs which are usually functional and the ones which usually keep your pressures all right. But the third one is a flat appearing bleb with subconjunctival fibrosis. This is a fibrotic bleb. And the last one, type 4, is an encapsulated bleb or a tenon cyst. So usually the type 3 and 4 are the failed ones, the type 1 and 2 are the functional ones, and it's important to recognize that. The new grading systems, I've just put them up, but you need a reference photograph next to your slit lamp to be able, it's impossible to memorize the 16 odd photographs all the time, but it's a useful, objective way. So there are 3 features, the height, the extent, and the vascularity. One is the Indiana and one is the Moorfields bleb grading system. The limitations of clinical grading is that there's no assessment of the thickness of the bleb, and the implications for aqueous diffusion are usually missed out. Bleb leaks don't come in the Cronfield classification, and bleb-related infections might be there, which you don't look at. Now, trabeculectomy can be very frustrating, and I just pulled out this large study that I found of 119 trabeculectomies with just 1 year follow-up. 78% more than 3/4 required some bleb manipulation. So nobody in the world does trabeculectomies and can send their patients home and say, we did nothing and it worked. 49% underwent massage on day 1, that's half. 49% required one suture removal by day 7, another half. 31%, about 1/3, required at least one 5-FU injection, most commonly given by day 14. And 25%, which is 1/4, required at least one needling and one 5-FU. And this was usually around day 43, which is about 6 weeks. So that's the typical course of trabeculectomies done anywhere in the world. So to think that we'll get away without manipulation is not true. The post-operative intervention is frequent. Trabeculectomy requires post-operative follow-up intensively, and it is labor-intensive. It's not an easy thing to do. So the things to sum up, to look for, there are several indicators that present to a risk of failure in which you should be extra vigilant: excessive conjunctival injection, corkscrewing of vessels, increasing IOP. Always ask yourself why. Is there an iris plugging the sclerostomy? Is it a high bleb phase, or is the bleb getting scarred and then it is flattened? Those are the typical 3 problems. Just to illustrate a high bleb phase, this high bleb, this is on post-op 1. This is with the 5-FU injection at day 7. By 6 weeks, you can see the bleb is looking a little high and the pressure is rising. At this stage, you need to give it a course of aqueous suppressants because there's too much of aqueous coming and the microcysts have flattened down and it is just not being able to go out into the subconjunctival space. So a short course of aqueous suppressants here. At 10 weeks, it's settling down, the bleb height is less, the IOPs come down, and now the timolol has stopped, and at 4 months, there is fluid and the bleb is well on its way to recovery. So it's important to recognize a high bleb phase, typically at about 6 weeks, and then do something. Just a word in case Ologen is used. The rationale is, suppose there's pseudo-exfoliation and an elderly patient, it's a go-between between doing an MMC and doing a plain trab in patients in which you'd like to augment a trabeculectomy, but you would not like to use mitomycin C. So it's a nice go-between them. But just remember, the Ologen looks a lot like a T-non-cis, so please label your records very, very nicely, because if you have an Ologen in place and then you inject 5-FU, that could be a bit of a problem. But this is the usual course of an Ologen, and this is just somebody about 1.5 years down. There's still fluid and it works quite well. So in summary, it's a beginning of a process, like we said, aimed at achieving satisfaction. But it's only the beginning. It's not the end. For some trabeculectomies, post-op periods involves many adjustments. Each of these has a specific role, either in isolation or in combination with all sorts of other interventions. So there's no hard and fast rule as to day 3 do this, day 7 do this. It has to depend on what your bleb is like. Recognition of the bleb morphology is the basis of intervening, but it's a sobering fact that despite all that you do, some trabeculectomies will ultimately fail. Thank you.